What's up? My name is Josiah Haken, and I've been working with homeless folks for over a decade. I'm convinced that one of the biggest reasons we have not been able to solve the homelessness crisis in our country is because we fundamentally do not understand why it happens or what or can be done about it. In this podcast, I'm going to interview friends of mine who have experienced homelessness firsthand, experts who have spent years of their lives trying to provide services and resources to their unhoused neighbors, and advocates and theologians who will help us think differently about the issue altogether. You are not going to agree with everyone I interview on this podcast. You may not even agree with me, and that is okay. Let's throw out our assumptions and consider the possibility that maybe there is more to this story than we previously thought. Welcome to the Neighbors with No Doors podcast. What is up, everybody? I am so excited to have you tune in for this episode of the Neighbors with No Doors podcast. I have a very, very special guest with me, David Velasquez. I hope I pronounced that correctly. David is from Los Angeles, California, and currently a fourth-year medical student at Harvard, who also studies business and policy. His work focuses on healthcare delivery and equity, paying particular attention to its relationship with low-income and marginalized communities. I can't even tell you how perfect that is for this conversation. Welcome, David. Thank you so much for giving us a little bit of your time today.
Thanks so much, Josiah, for having me. Super excited to chat.
So, David, to start off, man, tell me a little bit about yourself. How did, you end up in this field? You're, at Harvard, you've been studying medicine, but you're also the specific intention to low-income and marginalized communities. How did that happen? Tell me about yourself a little bit.
Yeah, fantastic question, and a big one that honestly we could spend an hour on itself, but I'll try to be brief, Josiah. So as you mentioned, I grew up in Los Angeles, California, but that's kind of actually misleading because I moved around a lot through Southern California, and it's hard to call one place home because I moved around very often when I was younger, and that's because my family was very low income. So my parents were undocumented for the first 6 years of my life. And then after that, and during that period, we were very low income, $6,000 a year for 6 people. I have 3 brothers that I grew up with. And so, this interest of trying to improve healthcare and just the general health and lives of people experiencing homelessness and marginalized communities in general comes from witnessing and living a lot of those experiences as a young child and an adolescent as well. Lived in Los Angeles, lived in shelter homes throughout. As we'll get to, that was family homelessness, which is different than adult homelessness and so forth. Moved throughout Southern California, went to the Antelope Valley, and there continued to experience a lot of these barriers, not just in terms of housing, but healthcare, right? Lack of access to healthcare, lack of access to education systems, or high quality education systems, I should say. And that wasn't just the case for me, but for people around me. And, one thing that I noticed that all these different factors led to was poor health. And so at the end of the day, I told myself maybe I could be a doctor that comes back and really uplifts these communities that have poorer health because of all the reasons I've outlined and more. And so that's what initially led me to think that I could become a doctor. Obviously, no one in my family had been a doctor. My parents have the 3rd and 4th grade education from their country in Central America, and my older brothers were expected to work after graduating from high school. So it was very a lonely path, a scary one with lots of uncertainty. But thankfully, because of my community, because of my parents, and many others, I made it here. And now, here in Boston, excited to chat with you about this topic.
That's amazing. It's so incredible. So this is personal, right? This is not something that's theoretical. This is not something that, for me, I mean, honestly, I come at this conversation, from a position of privilege. I grew up in West Africa. My parents were missionaries. So I was surrounded by developing world poverty, but I was always in the position of power and of privilege as, the white American expat who's there. And so I always take that for, we can only come into this conversation from the context that we've, entered into, we've come into it from. Right. And so I just love that, First of all, your story is incredible. And second of all, I love how, you're taking your experiences and leveraging them for maximum impact. And yeah, it's just incredible. So first of all, that's amazing.
Thanks so
So tell me, like, looking back, so if and this was, like I said, personal for you, was there a moment where you look back on and you're like, man, I just realized, like I realized the inequity hit me, like you became aware, almost like, like this consciousness of there are people who are doing just fine and have homes and access to education and healthcare, and I do not, or these folks around me do not. Do you have a specific memory where that sort of realization hit you?
I do, and that's such a great question, and it's one I've thought of a lot. So when I was younger, age 1 through about 12, 13, we moved around very often, as I mentioned, but to me, that was normal, right? To me, like, that was life, and that's how everyone lived it. And every single time, even when we were in the family shelter home, right? When you're in a family shelter home, at least back in 2001, they tried to make it feel like a home. And they would have, during the day, us kids, we would go and we would learn. And we celebrated my brother's birthday in a family shelter home, right? And so they really didn't make it seem like we were homeless per se. And then even after that, so once my parents received their permanent green cards and we qualified for Section 8 housing vouchers, we were in a house in Palmdale, California, and we moved every 2 years or so, primarily because there weren't that many protections around the program, and landlords were kind of able to do what they wanted in many cases. And so, but that to me, again, was normal. It was, we're moving because we want a better house, because, maybe this place will have a bigger backyard, or, the rooms would have a bigger closet or something like that. And that's what I thought was happening up until 2009. So in 2009, right before high school, we were living in, I can't even remember, maybe our 9th home at this point, in Rosemont, California. Rosemont is a very small town, about 15,000 folks in Southern California. And my mother stepped out as I was playing basketball with my brothers and a few other friends from our neighborhood and said, "You guys got to come in, pack your stuff, we need to go." It was very, very abrupt. And we did that. My brothers and I have 3 brothers, as mentioned. We went home. Inside, we packed, and they told us that we had to leave. So our house was foreclosed. And it was, at the peak of the recession, essentially. And I was about to enter high school. This was the summer before high school. So at that age, I'm becoming more aware of what's happening around me. And, quite frankly, I still didn't understand when my mom said, "Go pack your stuff and get everything in the van, and we got to go find a place." And we were going to spend the night in our van. Thankfully, we had a neighbor who lent my father some money, so we had a chance to go into a motel. And we stayed in this motel for about 2.5 months. So we stayed in this motel, very small, 1-bedroom motel with a studio, in a very deserted road in Southern California called Sierra Highway. And I was sleeping on a bed with my 2 older brothers, and my little brother was on the bed next to us with my parents. And we spent a summer there for about 2.5 months, right before high school. And when I really, that's when I really started noticing something's different here. Like, this isn't normal. Like, this isn't how I see my friends in middle school and in high school. And when it really hit me was when I was at basketball practice. I loved basketball. Basketball was my first love, and that's what brought me and my brothers together. And I would go to basketball practice, and when my friends would offer me a ride home, I always declined. And I would always say, "No, no, it's okay." And I started realizing it was because I didn't want them to see what was happening. I didn't want them to know that I didn't have a house to go to. And so I would just walk. I would walk about the 1.5 to 2 miles back and forth every day. And I would reflect, on those walks. And very similar story happened when, our bus was coming back from a basketball tournament, and we drove by the motel and saw the motel, and I didn't want to look at it. Right. And as a 13-year-old at the time, I was honestly embarrassed. I was ashamed, right? Because I was in that situation. My friends weren't. They all had a house. Not that they were wealthy, right? We were living in a pretty low income area of California. And so they weren't wealthy at all, but we were just really poor. And so that's when I started noticing, all these differences between us and them. And then later on between us and society in general, and how, it wasn't just us too, right? There were many people. There were people who were just across the street in the other side of the motel who were also spending, most of their nights there. And so, anyway, I can talk about this episode a lot because there are a lot of, different components to it. But that's the first time when I realized, wow, like we are poor and we are essentially homeless at this point.
So, and how did that? I mean, maybe it's just the wannabe psychologist in me, right? Like, like what is it that I'm just curious, like, as you look back on that season, and I know we're going to get into healthcare here in a minute, but, what is it about our society? I mean, that leads 13, 14, 12, to feel ashamed, because of their economic status. Because I remember there was one time I was doing outreach in Harlem, and this father and his teenage son, someone had handed them a flyer for our outreach vehicle and the location that we go to, and they had nowhere to go, and so someone supernaturally really just handed them a flyer randomly. I still don't know how they got it, but they walked like an hour and a half just to get to our outreach. And I was sitting across from them in a little office that we have in our mobile outreach vehicle. And I remember seeing the look on the face of the 16-year-old as his dad was talking to me about their situation. And I remember just feeling so just heartbroken. He was just so ashamed. And then I remember feeling so much pity for the dad. The dad was trying so hard to make the best of the situation and stay positive. And so I'm just thinking to myself, as you're telling, I kind of see you in that story, lined up with this young kid that I saw, and just think to myself, what is it about our society that leads us to that point of shame around factors that we have no control over, and things that you didn't do anything wrong. There's nothing that you did to deserve that situation. It just happened. But then there's that shame component. I don't know if you want to talk, if you can give me like 30 seconds.
Yeah.
What do you think about that? How does that happen? Why do we make kids feel like crap about the fact that they don't live in a decent place?
Right. I think it comes down to one word, and it's stigma. And I think you actually probably have done a lot of work around this, around engaging people, right, who are experiencing homelessness. I think we have a tendency, just even thinking back, right? So when I lived in Los Angeles, we were right by Skid Row. And Skid Row has, as you likely know, a lot of people who are experiencing homelessness. And even us, right, as low-income folks in that area, like there was this stigma, right? There was just walk straight kind of thing, like, just don't pay attention to them almost. And I think that translates over to you when you yourself are experiencing homelessness, even though you're not, say, on Skid Row, you are in a sense homeless, right? And so I think it has to do with stigma, and you feel that, and you feel like others will look at you and say, "Oh no, like you're experiencing homelessness, or you're homeless, and you're probably dirty, or like whatever," right? All these bad words that people associate with homelessness, and I think it has to do with that. It's a very quick answer, but I think it's around the stigma.
No, I love that. I mean, it's obviously terrible, but I mean, I love that you've summed it up with just that one word, because I think that tells me that there's something we can do about it, right? That tells me that we can destigmify homelessness and really make an impact, and hopefully, for the next generation of kids. I know, I think I read somewhere that the average age of a homeless person in the United States right now is like 10 or 11 years old, and so we have our work cut out for us, right? So, so tell me a little bit about, like, okay, so getting into med school, like so you wanted to, go into the medicine field. How did you get from California to Harvard?
Yeah, big question. I'll try to be brief. I think, I can take this many ways, but in summary, I think I had this mission, right, as I've talked about, of going back to a community, or somehow uplifting those who have been silenced, those who don't have a home and have felt marginalized, and have historically been marginalized their entire lives. And what I did in college was around that, right? I I started an organization in college, right, to bring healthcare services to low-income folks in the Los Angeles area. So like we would cold email doctors, dentists, nurses, Planned Parenthood, like all these organizations and say, hey, look, there are clearly people here who don't have access to healthcare. We need your help. We're going to set up this health fair. Can you please come on this date at this time? And that's what we did, right? It was very like, get your hands dirty, like just try to get out there and do something because we know the problem exists. So now let's try to solve it. Obviously, that is a very band-aid solution, but as a college student, it was all that I could do. And so doing those kinds of things, like basically sticking to that mission, I think is what ultimately led me here to Harvard Medical School. And beyond that, I mean, there are other things that college students consider teaching, research, etc. My research later on became more around underserved populations. In college, it's very easy to just try to tick some boxes on your path to medical school. And I advise a lot of students here, and that's typically what we see sometimes. And so my mission was, okay, let's do some research, see if I like that. Let's do some teaching. Love teaching. Love being able to empower others. And so ultimately, I think it was all those experiences combined together with that mission that I talked about at the beginning, which has been set in stone essentially and hasn't really moved ever since I had it, which got me here to Cambridge or Boston, really.
So let's talk about that healthcare aspect, right? And that was a lot of folks, I think, in well-meaning, folks in our country seem to be under the impression that, well, what's the problem? Isn't healthcare free for people in poverty? Don't they get free access to, isn't that what Medicaid is? What's the issue? Why are there people, using the ERs as their, as a revolving door for healthcare access? What is, so I just would love for you to kind of talk a little bit about sort of on a macro level, our healthcare system, and really some of the pros and cons and with, as it relates to homelessness and the unhoused community, if you can.
Absolutely. So much to say here. I think it's important to preface this by saying, this isn't a problem with healthcare alone, right? It's really this social care system that needs fixing. Like we need to have more affordable housing. We need to have more affordable childcare, better education, and so forth, as I've talked about and seeing those problems growing up. But healthcare is definitely a player and one in which we see problems and also solutions. So when I think about problems in healthcare and how they relate to people experiencing homelessness, there are two big buckets. The first one is around access. So healthcare access in our country has been an issue. We don't have universal healthcare. For the general population, about 90% of people have health insurance. It fluctuates back and forth depending on the administration, but typically it's around 90%. When we look at people experiencing homelessness, some estimates show that it's about 40%, right? And that is clearly very different than the general population. So issue number one is that people who have experienced homelessness or who are experiencing homelessness do not have access to healthcare. And that is a problem because they typically also have higher medical needs, right? They have oftentimes serious mental illness. They oftentimes will have other conditions such as COPD, congestive heart failure, etc., and a variety of others that we can talk about. Not only that, but them living on the streets will often result in medical problems that they then need coverage for. And so this issue of healthcare access is a big one. And in terms of what's good, what can we do? There have been organizations like here in Boston Healthcare for the Homeless program, right, who has a much higher insurance rate when you look at their patients who almost all are patients experiencing homelessness. And so they're doing a much better job, but that requires engagement, right? It requires going out into the community and making sure that when a patient comes in, you are signing them up for health insurance. And then another kind of problem around this healthcare access is that in some states, we just haven't expanded Medicaid, right? So this program that you mentioned just now, where we are providing healthcare for people who are low income, doesn't exist, or I should say, doesn't apply to certain folks, typically single able-bodied individuals in certain states. And so that has been, on the federal government's agenda, but still hasn't passed. And so access is a big one. And The second one is around healthcare delivery. So, what are we actually doing within our hospital or outside of our hospital walls to improve healthcare for this population? And when you look, I think the first problem here is that people experiencing homelessness will sometimes receive worse healthcare delivery as it relates to clinical services. There was one study, for example, in which patients who were homeless um, came in with an acute myocardial infarction, so a heart attack,
Hmm.
uh, and as compared to people who were housed, they had people who were experiencing homelessness had worse access to diagnostic and therapeutic services, even though they all came in with a heart attack, right?
Mm.
So we first need to ensure that when patients come in, regardless of your background, whether it's around homelessness, different language status, etc., you are receiving the same care that everyone else is receiving, which hopefully is high quality care. That's the first piece. The second piece around healthcare delivery now touches on this social service aspect, which over the last 10 years or so, we've seen healthcare transition more into this area. Um, I'll give you a story really quickly.
Yeah.
I met a patient at the hospital. I'll just say Mr. M for confidentiality for purposes. And I saw him while I was at one of the big hospitals here on my medicine rotation, and he came in with new diagnosis of HIV/AIDS. Young man in his 30s, and we took care of him. I saw him every day. We gave him all the best medicines that you could possibly receive if you come in with a diagnosis with HIV/AIDS. And after about 3 weeks, he got much better to the point where we discharged him. But when we were discharging him, we didn't know where to send him because he was homeless, because he had come in from a shelter home. And so what did we do? We had really no option. So we asked him, do you have a friend that you can probably go hang out with? And if so, that's what we're going to do. And that's what happened. So he ultimately went and he spent a couple of weeks with his friend. But what happened after that is that his friend no longer wanted him to live there, right? That was not a long-term solution. That was a very, very temporary solution so that we could discharge him somewhere. So about 2 weeks later, he ends up leaving the friend's home and actually goes back to an emergency department. And he comes back for anxiety because of that situation that was going on at home, because of the HIV/AIDS diagnosis that he just had 2 weeks ago and is barely getting treatment for. And this obviously creates a bigger problem, which we haven't even touched on, which is around healthcare utilization, right? For people experiencing homelessness who come into the hospital at times for preventable causes. And so, just to summarize, there's this access issue, a delivery issue, and the delivery really comes in terms of clinical services and social services. And we can do more for both of them.
Yeah, and that's so great. My questions, I mean, because what I've seen over the years is, you know, getting people, like, I love what the access, right? Like getting people access to care in cities like New York, for example. People should be able to go into emergency room or different health centers. New York City has tons of medical providers, but there's also, I think, connected to the stigma of homelessness. There's a lot of issues around what some people might call frequent flyers, or like the people who come in over and over again, and sort of the downside of that, which then becomes sort of this totally understandable but unfortunate sort of response to dismissing homeless people as either they're just trying to get a bed for the night, or they're just trying to get something else, but there may not actually be a very real health concern, and so homeless people end up maybe falling through the cracks with serious health issues because they are seen and sort of dismissed as sort of seeking behavior rather than someone who genuinely needs the health help. And then there's the other reality, which I've seen, is the unfortunate tendency for like you mentioned, I love the story because it's so true, like discharging homeless people to nowhere. During the COVID pandemic, we were one of the only outreaches that was still regularly out in the street, because 1/3 of the food pantries and soup kitchens in New York closed during the pandemic. And we ran into like 3 or 4 people over the course of a couple of weeks who had just had surgery, serious surgery, and were now sleeping outside because they were discharged because they technically didn't have any urgent need, like their case was not life threatening. They were technically treated. So because the hospital wasn't going to get payment for sort of ongoing, management of that care, they discharged folks and they said, well, just go, do a follow appointment in 3 weeks or whatever. But this is someone who's sleeping on the sidewalk with an open, like staples in his stomach still. And so there's this, in this reality of how are we overcoming the stigma of homelessness, and how are we providing that social safety net so that people without homes can access like the rehabilitation and the more long-term or recovery or preventative medicine that most of us just take for granted. I don't know if I'm making, I don't even know if there's a question there, but I'm just thinking out loud about kind of the things that you shared and sort of some of the observations I've made over the last, couple of years.
Yeah, no. I mean, I resonate with everything that you said, Josiah. I think, on the last point, and on my last point too, there is more that our healthcare system can do when it comes to thinking about the social side of things, right? Going off the story that I just mentioned, right? What could have we done better? I think there are a few things, and they relate somewhat to what you were just alluding to. One, well, we could ensure that we are systematically asking patients or screening patients for risk factors like homelessness and housing instability, right? And then two, we can ensure that we are connecting patients with either a case manager, right, in the community, or a center, right, that is going to be in touch with the patient, or a housing navigator, right, or someone. We need to have better connections between our healthcare system and our social care systems, and that's something that's missing. And perhaps an opportunity for organizations like yours, or many others that are trying to think of, okay, how can we better communicate, and how can we disrupt the silos that we currently live in, which unfortunately result in worse healthcare at the end of the day, or worse health really for patients experiencing homelessness.
So that's, yeah. And I would love to, continue, like you and I'm hoping we can continue this conversation. Maybe well, we're not be recording it, but that idea of providing that sort of that connectivity between, the health centers, the ERs, the, whatever, the surgeries, and the outreach teams, and the teams that are being contracted to provide that wraparound care. I think another thing I noticed during the pandemic was, I remember the first time I needed the doctor's appointment, and I did it via FaceTime. And I remember thinking to myself, this is incredible. I'm never going to the doctor's office ever again, because I can just now do it with my phone, and I can FaceTime my doctor, and it's great. And then it occurred to me how many homeless folks are not accessing their doctors because of a lack of technology. And is there a way for us to get creative with the delivery of healthcare services through technology to the unhoused community via drop-in centers or mobile outreach programs? And I've been trying to, I've been, for the last year and a half, been trying to figure out a way for us to increase access, and through the delivery system of getting, using technology to get people connected to healthcare. And we haven't landed on the magic, we haven't solved it yet, but it's definitely something I'd love to explore.
Yeah, no, I think that's such a great topic, right? Thinking about essentially digital equity, right? Like, how do we make sure that everyone is receiving telehealth if they need it, right? I think that it was one of the big changes that we saw over the last year or 2 years, really, since the COVID-19 pandemic started. And it's one that has been on my mind a lot, and one that I've been trying to figure out too. There is no clear solution, right? I think, one, yes, everyone should have some sort of mobile device. And there have been some organizations that are providing patients experiencing homelessness with mobile devices, from, I believe, from insurers to even the government at times. I think in California, they did that a few years ago, or maybe during the Obama administration. So getting them phones, or getting them somehow access, whether it's, a hub that you go to and that you can take a call, etc., is going to be very important. They also need to know how to use it, right? Like, oftentimes you can have a phone, but if you haven't ever really messed with it, even called someone via FaceTime, et cetera, it might be difficult for you to navigate, or if you have to log on to Zoom or whatever it might be. And so there have been some programs in which you have this digital navigator, right? A person who, at the point of discharge, will teach you how to use a device. And that, I think, is a newer model that we've seen over the last couple of years because of the COVID-19 pandemic and this increasing awareness that telehealth is very important and needs to reach everyone. And then three, I mean, this broadband access is another problem, right? Like, you got to make sure you have Wi-Fi if you're going to take a call, or a service, right, of any sort. And so that's another one. And there were times back in the day where I would go to McDonald's because that's where the Wi-Fi was. You're not going to take a telehealth call or feel comfortable telling your doctor about all your personal issues from McDonald's, probably. And so, how do we navigate that? So there are lots of different components to this digital equity problem that we need to be thinking about. And it's one that should be top of mind, especially since we're seeing care being moved either into the home or into technology.
Yeah, I man, it's so good. So tell me, like, from your experience, working in this field and, obviously, with your passion for inequity and marginalized communities, what are some of the most sort of urgent issues that we need to fix to get? I mean, we just talked about a couple of them, right? But like when it comes to providing access to healthcare, I think there's a lot of stigma around homelessness, particularly around mental health. That is an issue, and I think that there's also a lot of people out there who misunderstand the physiological realities of mental health and how that affects everything, which again you would think nowadays would be obvious to most of us, but unfortunately, we still have there's a lot of stigma there, and I'm just wondering if you have any thoughts on how we can better engage the issues of mental health, or if there are other things that you think are really pertinent around homelessness, that as far as healthcare is concerned, that are just really urgent, or maybe even low-hanging fruit that we can address. Where would you start?
Yeah, that's such a great question. I've mostly been talking at the system level, right? But there are also things that we as individual care providers can do. And I think, one is going back to the story that I talked about with Mr. M. There is a better way to approach that situation, right? Which, as I mentioned, involves one, understanding the situation. So what is life going to look like when you go home or wherever it is that we discharge you? And what can I do as a provider to make that better? So, for example, providers can say, okay, well, if you're not going to a home because you're housing unstable, maybe I should prescribe you a medication that you just have to take once a day instead of 3 times a day, so long as the outcomes are the same, right? You don't want to give someone some sort of inferior medication just because that trade-off might not be worth it. But thinking about those things, right? How do I prescribe that, or should I prescribe this medication, which maybe doesn't push you to go to the restroom 5 times a day, as opposed to this one where you can go to the restroom 1 time a day, because we know that people experiencing homelessness aren't going to have frequent access or reliable access to restrooms, and therefore it might not take the medication that's making them go 5 times a day. And so thinking about, our prescribing practices, even around cost, I mean, that's another big one, right? You don't want to prescribe a medication that they have to pay $200 for. They're never going to take it.
Right.
It
might as well be $1 million.
Right. It's like my parents who have a home aren't even going to take it, right? Because that's way too much to pay, and many other people won't take it. So can we prescribe more generic alternative that maybe costs $5, or that hopefully doesn't cost anything, right, for these patients? And so I think there are individual practices and considerations that we can take when it comes to us as care providers, as doctors, nurses, social workers, et cetera, when thinking about what is your environment going to look like and how can I adjust around that. So that's, I think, the almost low hanging fruit in a way, but it's that takes behavioral change, right? And oftentimes, as you likely know, behavioral change can be the hardest. Instead of just saying, okay, at the systems level, we're going to implement a program in which you click this button and then you'll call a coordinator to come talk to your patient about homelessness. and then they'll do everything. So it might be low hanging fruit in one sense, and that we have the power essentially to fix that. But in another sense, it could actually be more difficult since it disrupts some of our traditional practices.
So good. Sorry, I keep on saying that, but I'm just reveling in the moment. So so where do we start to educate and like the prescribers, and how do we again change the narrative around homelessness when it comes to medical professionals and insurance companies, and like, because I know for me, like, if I, as a nonprofit, right, like we have to apply for every dollar that we get. We have to like fight for funding, and I think there's a lot of people who are looking for the biggest bang for the smallest buck. And when it comes to homelessness and it comes to medical care, you don't often get the biggest bang for the smallest buck. It's more of a you get what you pay for kind of situation. So I'm wondering, like, how can we go about, or what would you tell me as as a medical professional talking to the CEO of a nonprofit? What can I do to help like change the narrative and help providers, healthcare providers, think about those things differently?
Yeah, I think there are a few things that come to mind, and something that's missing, from medical school curricula often, not always, but often, and also resident curricula or just the programs in general, are interactions, like real one-on-one interactions with people who are experiencing homelessness. And so, thankfully, here at Harvard, we have some exposure in that sometimes a doctor will bring in a patient who has experienced some sort of serious life event. It might not be homelessness, it might be something else. And we'll all listen, and they'll have a conversation, and we'll try to really empathize and learn and understand, the context of these individuals' lives. And so I think the first thing is basically doctors, from medical students to residents to attendings who have been practicing for 30 years, could benefit from just hearing patients out. Because oftentimes, I mean, yes, if you're a doctor, if you're an attending at, let's say, MGH, you are going to see a patient experiencing homelessness, no doubt. But are you going to spend an hour hearing their story, understanding how they live, what they've gone through, and the barriers that they're going to face upon discharge? No. Right? As a medical student with more time to see patients and to be at the bedside, even I'd have a hard time spending all that time because I have competing priorities. I have other patients to see. And so the question is, how can we basically provide this education to doctors, medical students, et cetera, in a way also that isn't exploitative, right? We want to make sure that we're not just bringing in patients experiencing homelessness for the benefit of doctors, right? We want to make sure that it's a comfortable setting, a trauma-informed setting for these patients who are experiencing homelessness. But I think the point is, right, if we could have some sort of connection between our medical institutions, and community health centers, or just health centers, or community centers in general, nonprofits, et cetera, a better communication, and perhaps almost having, people that you serve, people that you help and that you see on a day-to-day, be spokespeople, right? And be folks that can talk to us and let us know, like, look, this is what you're missing, and this is why it's important. Now, it's not all on the nonprofit. I think doctors and the medical institutions need to realize how important it is, right, for them to listen. And that's, I think, I don't want to say very hard, but they have so many competing priorities that I think it'll be hard, right, to institute some sort of regular practice that allows for that. But in an ideal world, I see one in which we have more of these communications, more of these listening sessions, because already, you can go to the MGH and we have grand rounds every week, right? You hear about some sort of medical condition and a patient and something that happened, but it always focuses on the clinical side. Can we have more of those that focus on the social side, right? On these life experiences that matter a lot, and that we can then hopefully think about as we treat the next patient and inform our practice, our prescribing practices, et cetera, around their care. So hopefully that answers your question.
It absolutely does. And then the follow-up would be, how do we encourage empathy from the standpoint of the funders and the insurance companies and I mean, is there a way for us to, like, even like the people, like you mentioned Medicaid and like the access to Medicaid in different states, and I know there's just so much stigma around, you know, homeless folks, you know, being considered, you know, why don't they just get a job? You know, that's how I get my medical care. I go out and I work, you know, but or so people say. But how does that like factor into our the conversation around access and healthcare on a macro level within employment structures? And I mean, how do you, because like I think I mentioned earlier, like you know, what does homelessness and healthcare like look like in the United States versus homelessness and healthcare in a different, like in Canada, for example, or in a place where there's socialized medicine? I'm just curious what your thoughts are as someone who's studying this. Like, what are some of the pros and cons of, you know, sort of our medical system with regards to homelessness that you may not see in say a different environment?
Yeah, no, that's a great question. So I think one thing we're seeing a lot in the United States that I believe is unique to the United States as it relates to healthcare and homelessness is that you have a lot more programs and initiatives that are raising tons and tons of money, right? So, for example, like Kaiser United Healthcare, they are paying for housing weirdly, right? They are doing that. MGH, they're thinking about it, right? There are hospitals, there are insurers that are going out there and saying, you know what, we're going to put millions of dollars into housing and homelessness, and food insecurity and education and so forth, because of X, Y, and Z. Now, I think we could have a whole discussion on whether that's a good thing or a bad thing. I think in general, the public sector and our government should be doing more around this, right? And uh, there could be competing incentives for why an MGH or an insurer might be doing this kind of work, and are they best suited to do that kind of work? Do they have the expertise required to ensure that patients experiencing homelessness or who are low income are going into that housing, are getting the care that they need, those wraparound services and so forth? That's a whole big question and a discussion, but I think that's unique, right? That is unique to what we're seeing here. Not that the UK, right, for example, I will say I'm not an expert in what the UK, Canada, et cetera, does, right? But just from having conversations and from reading a little bit, they are doing work around social care and so forth and so forth. But they have more robust social care systems in general, right? And say they don't need to think about should our hospital system be building this. Also, because you know their hospitals are often public hospitals. They do have private hospitals, but they have more than public than we do, and so they have a different strategy when it comes to thinking about health and homelessness than our healthcare system here in the U.S. does. I think in general, then it's the building housing, right? The really these massive projects that are unique to the U.S. The coordination and the screening that I talked about earlier, I think has been seen across different countries as well.
So I was just saying that it's interesting to me the stereotype of homeless people being lazy. I think is a significant detail. I also think that our system of connecting healthcare to employment is a significant factor, especially for people who I meet in the street who are working like minimum wage jobs. You know, they're cobbling together a lot of employment opportunities to try to scrape by, but none of them offer healthcare access. None of them offer. So I'm just wondering, from your perspective, how can we be solutions oriented? What do you think is maybe some tangible things that we can do to improve and increase access, and the things you mentioned in there, you know, earlier in terms of creating that more equitable healthcare system? But what are some things that you think are like we can do this to improve the Medicaid process or improve access to healthcare services for the homeless community?
Yeah, another big question, Josiah, but happy to tackle it. Um, there are so many things that we can do in general to improve healthcare access and delivery for people experiencing homelessness. I think one, we first need to ensure that everyone has a primary care provider. Everyone has a home that they can go to and see a doctor when they need a doctor. That means we need to ensure everyone has health insurance. That means we need to ensure that the Medicaid program is operating in every state and covering everyone it should cover, which currently isn't the case, as we've talked about earlier. Um, that means that it also needs to be affordable, right? Even if you're providing someone with health insurance, they're not going to show up if they have to pay, $80 just to see their PCP, which I saw with my family, right? When they did have health insurance, they didn't want to go because they couldn't afford the payments. And so we have to make sure that those co-payment agreements are low enough for patients to actually show up to the doctor. I think more importantly, though, we need to take a step back and look at health holistically, right? Like the medical industry is important. We need doctors when someone's sick, but we also need to think about how to prevent illness in people who are experiencing homelessness. So really, honestly, the biggest thing we can do when it comes to health for people experiencing homelessness is to empower them economically, right? Ensure that they are being paid a living wage, regardless of which job they have. Ensure they have a home if they want a home, right? And ensure that they have a case manager or social worker who is working with them to help them advance on this housing continuum, and also on the healthcare continuum. So like looking a bit upstream and saying, how can we ensure that you don't have to have, say, your foot amputated, right? Because you had uncontrolled diabetes or something. Like, how can we ensure we don't reach that point? Like, that's how we should be thinking about healthcare delivery for not just people experiencing homelessness, in my opinion, but for everyone. Right, we have to take this prevention lens, and so I think that's looking upstream a bit to the housing, the employment, the education for children, right, and young folks experiencing homelessness is super important. And then looking a bit more downstream on the healthcare side, making sure everyone has health insurance, making sure everyone has a doctor and can see a doctor, and also making sure that the providers and clinicians who are seeing patients are accountable, right, to the care of these patients. It's very easy right now in many hospitals for a patient experiencing homelessness to show up and be viewed as almost as a revenue machine, right? Where because they have all these illnesses, they are actually providing the hospital with revenue. And we are thankfully transitioning into more of a value-based care world where clinicians have to think about, okay, how am I going to prevent illness? Because I'm being paid differently in a way that doesn't incentivize volume, but rather incentivizes value. Us moving into that world, I think, is going to do tremendous things for people experiencing homelessness and all other medically underserved folks.
That's amazing. And I'm catching a vision for what you're describing. And I just can't, I can't think of, how it's just so important, right? It just changes the game completely. Tell me, you've been working, obviously, you already described sort of your childhood and the experience you've had with homelessness yourself, but now, with you studying at Harvard and going into this world, I'm wondering if you could tell us a story or two of people that you've met who are in the street, who needed access to medicine, and how your experience and how your medical, expertise and your education and all those things have allowed you to kind of engage in those specific cases and what you took away from them.
Yeah, that's a great question. One story I'll actually tell you, it happened outside the hospital, very related to everything you just asked us. So this was during, I think I was maybe right after my first year of medical school, if I remember correctly. I went home to the Antelope Valley in California. And as I was driving to go pick up some food, I saw a man just sitting there on the side of the highway at where you get off the freeway. And it was about 105 degrees outside. It was summertime. And he was wearing a black sweater, hoodie on, just had a sign that I couldn't read because he had dropped the sign. And so when I went to get food, I felt like the man needed help. He really needed help. So I also ordered some food for him, parked my car, went up to him, and I tapped him. I don't think he expected me. And I said, "Hey, man, like, what's going on?" Just trying to talk to him, just like any other person, right? Like that he is a person. Nothing strange about that. And then he kind of looks at me, takes a while, and finally opens up. And what he tells me is, He was just kicked out of his home because he has schizophrenia, and unfortunately, the his caregiver could no longer handle him because he wasn't on his medications, because he didn't have access to his medications. He didn't have them at all. He couldn't get refills. And we went back and forth. And, I asked him if he had tried the clinic that was down the street. He hadn't heard of it before. Um, the point is, though, he was on the streets because he was a patient with schizophrenia without access to medicine. And that just shows you how, lack of access to healthcare, lack of access to vital medicines, whether it's for schizophrenia or others, can really spiral, right, and result in a patient being homeless at the end of the day. Um, I wish at that moment in time I had more to help him. Really, I couldn't do more besides say, here's some food. There's a clinic. I really want you to go. He wanted to stay and sit, and that was, okay. Um, but that was one story that will stay with me for forever, really, because of the fact that this is a patient with schizophrenia, and we really need to help people like that. The other story that comes to mind was during my second year of medical school, where when I was here at Mass General Hospital, and I met a patient who I'll just nickname Mr. V. Um, and this patient came in with a diagnosis of HIV and AIDS, new diagnosis, very sick. He was coughing. He had all the symptoms of AIDS crisis. And I got to know him very well. He told me about his background. He was actually from Los Angeles. And so we connected on that level too. And by the end of it, we did all we could, and he got better. He got so much better. We gave him the Biktarvy, we gave him the antibacterials, all the medications that he needed in order to fight the illness that he was going through. But the issue was that we didn't do anything for his housing. He was homeless. He came into us from a shelter, and we really had no solution to that. We didn't even really have a connection to the housing ecosystem in the greater Boston area. And so when it came time to discharge him to home, we asked him if he had a friend who would allow him to spend the night with him. And so the friend thankfully said yes. We discharged him, but 2 weeks later, Mr. V came back to the hospital because of anxiety, because his friend no longer wanted him there, and he was supposed to be there for a temporary stay. He was there for 2 weeks at this point. His friend said, it's time, like, you need to go. He had nowhere to go. He went to sleep outside. He was sleeping on the streets where his medications were stolen. He was assaulted. And then he showed up to the emergency department, as mentioned, with anxiety and also stolen medications, where not my team, but a different team saw him and provided him with a refill. And so I think this is one of those moments where, I feel like we failed them as a healthcare system and as really healers. I mean, we were supposed to be healers. We were supposed to, think about the patient holistically, and we failed to do that. And thinking back, like, what could I have done? What will I do better in the future? One, I will continue hearing these patients, hearing them out, understanding them to the best of my ability so that I can help them. And two is really connecting them to the greater housing ecosystem. So, what we tried to do after that moment, I worked with a team with Dr. Alistair Martin and a few others in order to improve the way that we deliver healthcare for patients experiencing homelessness at MGH. That meant screening, that meant hiring a housing specialist, and that also meant committing MGH and all the other hospitals in the area to permanent supportive housing, to funding that. And we worked on that initiative for a while with the idea of, let's do better for these patients, right? We can, and we see a path forward, so let's tackle it. The COVID-19 pandemic unfortunately hit at that point, and hospitals like MGH said, we can't take on any projects, we're not going to add any new staff, et cetera, et cetera. So we've been on pause since then, but there have been many instances where we are seeing hospitals, clinicians, really these advocates who are coming and saying, hey, we need to do a better job of delivering healthcare for people experiencing homelessness. The way we're going to do that is by screening better, is by understanding their stories, and really delivering care in the way that fits their context best, in addition to connecting them with a larger housing ecosystem through a case manager or a housing navigator. And then ultimately, what we all want is somehow to house them. And we don't know, we don't have a solution yet. There are many groups who are trying to build housing and so forth, but that is what everyone deserves, a house. And so anyway, those are two stories that really will stick with me forever, and that kind of showed me where the gaps were and showed me where we need to go.
Yeah, absolutely. And those stories obviously just triggered a slew of stories in my head, in terms of, I mean, I know a guy in East Harlem who had a traumatic brain injury and had seizures. And he was living in a shelter. And every time he had a seizure, his prescription bottle would fall out of his pocket, and people would see the prescription bottle and they would steal it, because they were hoping that it would be some sort of opioid or something that they could sell or use. And he would end up, he was on Medicaid, and they would only fill, one prescription every 30 days or so. So even getting a refill for him was a challenge, because if it has happened regularly, just having access to that medication is just so challenging. And then I knew another gentleman who was very like learning disabled. He was like like a 15-year-old sort of in a 50-year-old's body. And he was in the shelter and was just, just chronically abused and taken advantage of, because he was an easy target. And I think even just that vulnerability that people in the street experience, in addition to, I think you mentioned earlier, just the increased health issues that, living in the street just sort of intrinsically brings, with infections and, health issues that are, chronic health issues that don't get better when you're not sleeping, and you're not, taking care of yourself, eating healthy food. And there's so many, health implications to survival, living in that sort of constant fight or flight mode. I tell people a lot, you can't live your best life homeless, just can't. And so, trying to access care, and I love what you're, in terms of the vision that you're casting for where we can go. I just really, really appreciate that. So let me try to land the plane a little bit here. I know I've taken a ton of your time. Thank you for your patience and graciousness with me, in terms of my technology woes. To people who are listening, this has taken like 4 different tries to get David to get him together. So he's been very gracious and patient with me. If you could convince everybody listening, one thing, if you knew, like, okay, I could say one thing that would resonate and that would stick, and everyone listening would walk away with a maybe a corrected perspective, around the issue of homelessness and or healthcare in this case, what would you say? What would you say if you were like, okay, I know I have a captive audience, and if I'm going to say this, and then it'll stick and people will walk away thinking differently? What would you say to people?
Oh, such a big question, Josiah. All the big questions. I love that. Um, I think I would say people experiencing homelessness are a diverse group of people. I think that often gets lost when people think about this group. I think we often jump to conclusions as to what this person looks like, who they are, where they're from, what mistake they made, etc. Uh, and I would push against that, right? I would say, look, I experienced homelessness in the past, right? You're listening to me, and if we talk on the street, you're not going to say, "Hey, this guy probably experienced homelessness at one point." I have a few friends who were also in that situation, and you would not think that, right? There are women who experience homelessness who have entirely different experiences than men who experience homelessness because of abuse, right? And all these other issues that come with being a woman on the streets. And there are families with children, right? When my parents I believe it was 2019, were temporarily living in a motel, across from them was a family with 3 little children, who were experiencing homelessness, in that they had lost their house, were temporarily living in this motel, and had nowhere else to go. And I can go on and on about the different faces of homelessness, but the point is that this is a very diverse, heterogeneous group that is unique, that requires empathy, right? That requires us to just take a step back and say, hey, like, these are people, right? These are people. They have their life experiences. They aren't homeless because they made a mistake, and they are just intrinsically uh, at fault of something. These are folks who somehow, because of likely the world in which we live in, they ended up being homeless, and we need to do something about that. And so I think that's the final message that I would leave viewers and listeners with. The homeless population, or people experiencing homelessness, we're all around, right? We all have to do something. We're all people. We're all unified in one way or another.
That's beautiful. And it reminds me of one of my favorite, I was at a conference once, and it was someone talking about trans rights. And the person said, when you've met one trans person, guess what? You've met one trans person. And I've taken that from, I think it applies to homelessness too. Like if you've met one homeless person, guess what? You've met one homeless person. Everybody's situation is unique. The last question, I promise, is the last one. What are some things that you do on a regular basis, or that anyone listening can do to help their homeless neighbors? I think a lot of people assume, they'll say, look, David, you're a med student at Harvard. Josiah, you're the CEO of a nonprofit that helps people. Like, you guys are helping people because this is what you do. But what can I do? And so I would say, what are some things that you do to help your homeless neighbors that anyone can do?
Yeah. Well, I think anyone can advocate, right? I really do. I mean, advocacy comes in many forms. It could come through a simple blog post, for example, right? Saying, hey, this legislation that is going to tear apart everyone's tent encampment is not right, right? I think advocacy, you can write a blog, you can, start a podcast, right? You can film a video, you can write to your representatives. Like, there are many ways in which you can advocate for people experiencing homelessness, and really many other marginalized groups. So I'd say that's definitely one thing. Just find the way that you like to advocate, and then push down that route. I think the other thing is, this will never solve the problem. Going back to the story that I talked about, how I went up to a person experiencing homelessness and I said, hey, like, here's lunch, right? Like, that is never going to solve the problem of homelessness, but it is something that we can do in the moment to just make someone's life a little bit better, right? Acknowledging folks, whether you don't have to go out and buy a meal or anything, right? Like, I understand, like, a lot of folks don't have time, they're going to their job or whatever it might be. But if you do have time, that'd be amazing. If you don't have time, a simple acknowledgement, I think would go a long way. And so these are like things that I think we can do on a daily basis to really just improve the way that we interact with each other. Not just people experiencing homelessness, but everyone, right? Because they are part of everyone.
I love that. I love that so much, because it's so true. The way we interact with people in the grocery store and at the gas station and, at the mall, like there's interactions. Like I always used to tell people, rules of social engagement apply. Like just be a human, like see the person, acknowledge them. So it's just so beautiful. David, I just want to thank you again for your patience with me and my technology woes. But most of all, your work, your story. I love how you're just leveraging every ounce of energy and time that you have to make this world a little bit better. So thank you so much for taking the time to talk to me, and thank you for all the work that you're doing.
Well, thanks so much, Josiah, for having me. Really appreciate it and love the conversation.
I am so grateful that you took the time to listen to this episode of the Neighbors with No Doors podcast. I hope you found it helpful and empowering. Just so you know, I'm releasing a book that is also going to be called Neighbors with No Doors, and I would love for you to check it out. You can find it at neighborswithnodoors.com. You can like our Facebook page or follow along on Instagram and Twitter. I'd like to thank my producer, Rex Harson, for helping me put this together, as well as the many guests who gave me the gift of their time and their story. Have a great day. We'll see you next time.